Okay, so the last of our respiratory disorders that we're going to talk about today is acute pharyngitis. And all acute pharyngitis is a sore throat. It can be caused by a virus. It can be caused by any of the rotaviruses or the pseudopharyngeal viruses, or it can be caused by a fungus. But the biggest one that we see is strep. Some of the problems that we can see with this is odynophagia, which is difficulty talking, and dysphagia, which is difficulty swallowing. The management, first thing we want to do is we want to culture. There is a rapid strep out there that takes less than 10 minutes. So you would want to culture your patient's throat first, of course, with a physician's order, to make sure it's not strep. We know that when it comes to strep, if it's left untreated, it can lead to rheumatic heart disease. And so for our cultures, again, we want to look at our rapid strep. If it's not strep, if it's a fungus, or if it's a different bacteria like staph, or it can be because of Klebsiella, that'll show up too. But with culture, it's going to take at least 24 hours. We can also look at our CBC, our complete blood count. We're going to look at that white blood cell count. If it's bacterial in nature, we're going to see a white count that's elevated, and we're going to be looking at the neutrophils, and that's going to tell us it's bacterial. If we look at the lymphocytes, and that's elevated, that's going to show us that it's viral in nature. We can also take a health history, and our patients will tell us that they developed a sore throat because, and it could be that there's a bunch of family members that have had strep, and so we're going to look at that. The treatment, if it's viral, we're just going to leave it alone. Eventually, it'll go away. Drink plenty of fluids, saline gargles. If it's bacterial, if it's strep, we're going to use antibiotics. If it's fungal, we're going to use antifungals with it. So depending on what's causing it is going to be the treatment. We're going to use saline gargles. You can use Vicks. There's a lot of home remedies. My mother's favorite was chicken soup if you had a sore throat, because it was soothing. Honey and lemon, that also will be helpful for pharyngitis. Last, we're going to talk about head and neck cancers, and I'm just going to basically cover this very quickly. When it comes to head and neck cancers, our patients, a lot of them, we'll see this, and the rate of curing it is very low. We'll talk more about head and neck cancers when we talk about oncology, but know what happens is that you have cellular changes from a constant irritation, whether it's cigarettes, whether it's alcohol, whether it's smoking, talking. We've seen the one that I can remember that's just been recently is Adele. She wound up having a laryngeal polyp, which was cancerous, because what does she do? She sings. So we have these cellular changes, which develops into our lesions. And from there, again, it can spread. And we know that it can spread to the brain because the brain is the closest, and it can spread throughout the body. Again, our risk factors: smoking and alcohol, smoking and singing. The prevalence is pretty, I'm not going to get into the statistics on that. Now, we can have three different kinds. We can have a glottic. So this is on the glottis here, right here. You can see the changes. Here we have a supraglottic, so this is above the glottis juncture. And you can see this kind of white patchy, and that's actually the tumor. And then we have here, we have a little subglottic polyp. So risk factors, most important, tobacco and alcohol. If you drink and smoke at the same time, well, not at the same time, but if you drink and smoke, you double your chance of getting head and neck cancers. Some of our other ones: chewing tobacco, pipe smoking, marijuana, voice abuse, chronic laryngitis, industrial chemicals, and neglect of oral hygiene. So all of these can cause our head and neck cancers. So management. So number one, is the warning signs. Your patient may complain of a hoarseness of their voice, and this can be sudden, or it can be typically it's ongoing. They may have some difficulty with swallowing, depending on where the cancer is. We want to take a health history. Do they smoke? Do they drink? Do they do drugs? Do they do, are they a singer? Operatic singers have a higher history of laryngeal cancer than our everyday people. We also want to do a psychosocial assessment, and this is particularly important if our patient's going to have surgery. Because if you think about it, the larynx is what we talk with. And I remember one surgery that I assisted on. It was a patient down in Phoenix, and we started out at the larynx, and we started dissecting this tumor. And it wasn't until we cut through the tongue that it really got to me how big this tumor is. So this patient has a life-altering surgery. He won't be able to eat. He won't be able to speak. He won't be able to breathe on his own for a while. He's going to have this tube out of his neck. So you want to do a psychosocial assessment. What is your patient's mental status? Do they have a support system in order, because this is a huge major surgery. Our diagnostic studies, we want to do a laryngoscopy, which is a lighted tube that goes down the throat into the trachea, looking at where is the tumor. We're going to stage it. We'll talk more about staging again in oncology, but the tumor, the nodes that are involved, and if there's any metastases, the TNM. So treatment can be non-surgical, radiation therapy, if for those patients that have spread of the tumor to the surrounding tissues or to the head, or sometimes it goes down into the lungs. Radiation therapy may be their only option. So, again, we'll talk more about radiation therapy when we get to oncology. Surgical, they can do a laryngectomy, or they can do a subglottic removal of the tumor. This is going to involve a neck dissection. And so, of course, we need to maintain our airway. So our patient's going to have a tracheostomy tube. This is why pre-op teaching is going to be ever so important for our patients. We spend a day to a day and a half doing pre-op teaching, looking at all of everything that our mouth does, our mouth and our throat do, is now going to have to be done some other way. So when we look at head and neck cancer, here you can see this patient had a pretty massive surgery. Of course, number one is going to be airway. And our airway is going to be managed probably through a tracheostomy tube. This tracheostomy tube may be temporary or may be permanent. So we're going to be looking at airway maintenance. So and I will tell you that tracheostomy tubes, when they are first put in, are very, very juicy. So you're going to need to suction those and maintain a patent airway. Also, oxygenation. Nasal cannula is not going to work for these guys because they're no longer a nose breather. So you're going to have a tracheostomy collar on to provide oxygen. We want to monitor vital signs because when we look at where is it, what's right next to our trachea and our larynx, we have the internal and external carotids and the jugulars. So we're going to be monitoring our patient for any bleeding, looking for hypotension, looking for tachycardia. Pain management, another huge problem because, again, we have a huge surgery. So, but how is our patient going to talk to us? Now they may have had a laryngectomy. So now, how are they going to tell us they're in pain? Another problem that we may see is nutrition. How are we going to feed them? Typically, with our patients that have had a laryngectomy and that have a tracheostomy tube, are going to have a gastrostomy tube. And this was one of your pretest questions. We got to be able to feed them until we can rehabilitate them and to be able to swallow again. So nutrition is going to be important. Typically, our patients that have had a laryngectomy, we start them on intravenous nutrition, and then we'll switch them over to a GI. This surgery is very, very debilitating. So they're going to need an exercise program. They're going to need, patients that have laryngectomies are in the hospital for 5 or 6 days. So we're going to need to start them on an exercise program. Get them up, get them moving. This is going to help us with our DVT prevention. This is going to help us with respiratory management. They're going to need some type of voice rehab. So there's several different items out there. There's the electronic voice box. There is the, not only the electronic voice box, there is the, it's a little flap that goes on top of, that goes in the trachea over the epiglottis, and I forget what it's called. It's DePuy, it's the Baumsinger voice prosthesis that is actually inserted into through the tracheostomy to help with speech. They're also going to need to learn stoma care. And not only are we going to we're going to do stoma care, but our patients are going to need to do stoma care when they go home. So this is going to be really important, and that's why a psychosocial assessment is so important, because this patient is going to have to manage their airway when they go home. These are our different types. This is the voice prosthesis. There's a video. I will post it on Canvas to show you. It's a long, involved process. There's like 12 steps. So when you're teaching your patient, this is one thing why speech therapy is ever so important, because is your patient going to be able to manage all 12 steps in putting in this voice prosthesis? And they're only good for 7 days, so they're going to have to take it out and put another one in. So that's posted on Canvas for you to review, and I hope you have a great day.